Good morning, everyone. Thank you for joining us today for this presentation to the CTN Adolescent Interest Group. We are very fortunate to have with us today Dr. Cady Berkel, who's an associate professor at Arizona State University. Her research focuses on reducing health disparities in substance use, mental health, HIV, and obesity by advancing equitable access to evidence-based prevention interventions for adolescents and their families. She studies the implementation of evidence-based programs in community settings, including healthcare, school, and court systems. Her work evaluates implementation mechanisms that promote positive outcomes for programs delivered in community settings through behavioral observations and machine learning. Dr. Berkel's work to embed parenting interventions in primary care has been recognized by NIDA's Substance Use Prevention Services in Primary Care Challenge. She serves in several national leadership roles, including as a member of the National Advisory Council for SAMHSA's Center for Substance Abuse Prevention. She's also a subject matter expert for CDC's Community Preventive Services Task Force and co-chairs the Society for Prevention Research Standards of Evidence Task Force. Today's presentation will share findings from a program of community-based research conducted in partnership with pediatric primary care and family courts to advance access to evidence-based substance use prevention for adolescents and families. Without further ado, please join me in welcoming Dr. Cady Berkel. Dr. Berkel, the floor is yours.
Thank you so much. Thanks to everyone for being here. As Jose mentioned, my work sits at the intersection between health equity, implementation science, and prevention. So that's what I'm going to talk about today. Let's see. All right. So I always like to start with the parable, the river parable. You may have heard it before, but I think it's a nice kind of orientation. So there's a man walking on a bridge across a river and looks down into the river and sees a baby floating down. And he thinks, oh my gosh, there's a baby in the river. So he just immediately jumps in, grabs the baby, pulls it to the side. And as he's going to the shore, he sees another baby coming down. So he runs for that other baby. Now he's got two babies under his arm, running to the shore, and there's a third baby. So he's trying to get that one and sees a whole bunch more. So another man walks by and the guy calls to him, hey, can you come and help me, please? Get these babies. And so the other man jumps in and they're gathering all the babies, but the babies just don't stop coming. Then a woman starts crossing the bridge and they call up to her and they're like, hey, lady, come help us. We need to rescue all these babies. So she keeps walking. And they're like, what are you doing? Are you like completely heartless? Why aren't you saving the babies? And she said, I'm going to go upstream and figure out who's throwing the babies in the water and stop them. So that's what prevention's about. We're trying to stop the flow. Of course, we're not really talking about babies here. We're talking about just the increasing rates of substance use disorder. And we can't just keep it going person by person and trying to treat the problem. We need to stop the flow from the source. So that is what I am passionate about, is stopping the source. I think we need to also keep in mind when we're thinking about equity, just these patterns between the same groups, in our society are the most affected by adverse childhood experiences, the most affected by social determinants of health. And those things in combination are really what's driving health and social inequity. So this quote by Harriet Washington about patterns being too consistent to be accidental is something that I definitely keep in mind as I'm doing this work. And we really need to be thinking about those things if we really want to make change. I think a lot about both questions related to interventions themselves, as well as intervention contexts where things may be implemented. And we really need to be keeping both of those things in mind if we're thinking about equity. So starting with, is this the right intervention? It's kind of irresponsible to go down the path of looking at implementation if we don't know that this intervention is going to address the issue within the population that we're interested in. So thinking about, just starting from the beginning with epidemiology is, does this intervention actually address a problem that is an issue for this community? In terms of etiology, does it address salient, maybe culturally specific risk and protective mechanisms for that population? And then in terms of efficacy and effectiveness data, is there evidence that it leads to the desired outcomes? That effects are at least as good with a priority population as a non-priority population and does not produce any iatrogenic effects. So that's on the kind of intervention side, but then in terms of implementation, we really need to be thinking about the context and starting with a lot of the work related to equity in the implementation science field right now is kind of promoting the idea that reach is the first step. So we should be partnering with organizations that actually do serve the priority population. And if we're not doing that, then we're not going to solve problems related to disparities. Thinking about adoption. So these are informed by the REAIM model. There's been quite a bit of work within the REAIM framework to incorporate equity principles. So adoption, is the system or organization willing and able to adopt the intervention? So if we create something that's so complicated that no one can adopt it in lower resource communities, then that's a problem. Thinking about implementation. So we talk a lot about fidelity and adaptation. And so sometimes sticking rigidly to the content of an intervention is not the most important thing. Sometimes there are other aspects of implementation that are important, like how much can we adapt the content to the needs of the population we're trying to serve. And then finally, maintenance. Are there mechanisms to support this? We oftentimes go into settings, do our randomized trials, and then, at the end of the day, there's nothing in place to sustain that. And it can have a detrimental effect of organizations where they're having to decide where to invest their resources. And, even if you're bringing in resources into a setting to do these kinds of trials, once they could be investing their time and efforts in other ways that may be more sustainable. So it's really important to think about that kind of thing from the get-go. So just kind of in line with that, starting with epidemiology, thinking about substance use in communities that are most affected by inequities. We do see there is evidence of somewhat of a crossover effect for some populations where there's lower levels of use in adolescents, but that translates into higher use and higher problems later in life. And you can see that these patterns, this is from NSDA data, if you look at the blue bars, that's for adolescents, and then the orange bars are midlife. And then oftentimes, in many cases, it's kind of dropping, but you can see with in white communities, the drop back down with substance use disorder from kind of early adulthood to later adulthood is much less dramatic in the communities most affected by disparities. So that's really important to keep in mind. I do want to point out that it's not that there's no use among early adults in the Native American population, that there's just missing data there. And the same with Native Hawaiians and Pacific Islanders. I also want to point out access to treatment. So this is kind of going back to the river story, where only a fraction of um, individuals with substance use disorder have access to treatment. And there are disparities in this area as well. So just again, reemphasize the need for prevention. 1 in 10 adolescents who have a substance use disorder, less than 1 in 10 receive treatment. Relapse rates are high, 50% within 12 months, and there are inequities in treatment completion as well. On the other hand, substance use that begins, or I want to make the case for prevention, substance use that begins before age 15 increases lifetime substance use disorder by 4 to 7%. So intervening to prevent that early initiation has a big impact across the lifespan. Um, and prevention can delay initiation and reduce escalation, cutting later treatment needs by 30 to 40%. Every dollar spent on prevention saves $18 in later costs. And so, really thinking about how much we invest in treatment versus prevention, like we really need to take a more comprehensive approach and be focusing on both. Um, so I've been part of this Community Preventive Services Task Force review of substance use prevention. And primarily, we spend a lot of time looking at family-based preventive interventions. So they've come up with a conclusion that there is strong evidence to recommend family-based interventions. And this is part of the kind of pathways by which, in their review, they found that family-based preventive interventions have a positive effect. And this is a very complicated slide, but what I want to point out here is that these interventions don't just affect initiation and substance use over time, but they also have these other effects. So sexual risk behavior, mental health, educational outcomes, and so forth, that kind of lead to disorder, morbidity, and mortality over the lifespan. So that's an important consideration because investing in these types of interventions has really broad scale effects. So just to kind of reiterate that, evidence-based preventive interventions prevent all of these things, basically have an impact on all of the good things we want for kids. But these, at the end of the day, these programs have not been made available to children and families. There's a estimate that 90% of proven behavioral and mental health interventions have yet to be used by practitioners. So that's a big problem because these things are funded by taxpayer dollars, and not translating that into actual benefit for the population is a big problem. So one thing, just pulling in then to kind of the mechanisms by which interventions work. I really love this. These are my colleagues, Brer and Castro, and they put out this heuristic framework for cultural adaptation of interventions. Oh my gosh, it's almost 20 years ago now. We need to have some kind of a celebration for that. But so basically, the idea is that interventions, when we want to make them more relevant for populations affected by inequities, that we include these kind of common mechanisms. So in family-based preventive interventions, a lot of times that includes positive relationships between parents and children, and good communication skills, and positive discipline, and so forth. So that's the kind of common mediator pathway that's showing up here. And then we have to take into account also the unique elements. So the unique stressors that they're experiencing, discrimination, for example, immigration stress, and that those are associated with common outcomes, but also unique outcomes. So thinking about, some of this, let me jump into an example of this is with, so I worked with Velma McBride Murray and Jean Brody on the Strong African American Families program. This is a family-based preventive intervention. It's similar in structure to the Strengthening Families program, if you're familiar with that. but went through a process of community-based participatory work to adapt it for rural African American families. And so it has the kind of general aspects, positive relationships, communication, discipline, but then also these culturally specific protective mechanisms like racial socialization and racial pride for the adolescents. And kind of overlays both of those like more general or universal mechanisms along with the more culturally specific. So this study was done back in the mid 2000s, and we did a trial of the SAFE program. In multiple counties across rural Georgia with middle school adolescents and found really great results. Like this is just one example of some of the findings that we've done or studies that we've done using that trial. But basically, this one is showing that SAFE works by improving parents' use of racial socialization and which in turn influences adolescent Black pride, which promotes psychological functioning, which prevents against all of these outcomes. So we're looking at academic failure, sexual risk behavior, justice involvement, and substance use problems. So we had a previous study that looked at initiation, but this one is focused on specifically problems. So that's really great. And again, there were tons of studies. There was, studies on mental health, all kinds of positive effects, even effects on parents, mental health as well. So that's really great. And then that's where we, come to the conclusion like, if you build it, well, they come. So like this intervention works and people love it. And so it's going to get scaled up and, going to make a big difference for the community. But yeah, we learned a long time ago, like it's maybe more complicated than that. So there were many challenges to implementation. It was costly to deliver this intervention. There were intensive supports for parent participation. So for example, there was transportation, meals were provided, childcare. It was set in community settings that parents felt comfortable with. There were like games and like prizes for attendance. But attendance challenges remained, and it was really something kind of insurmountable where like families were, working in kind of shift wage jobs where their shifts would change from week to week, and they really couldn't predict, am I going to be available on a Tuesday night to attend this intervention? We also saw a lot of variability in fidelity. So, coding the sessions to see, were all these points covered? This is just kind of a mapping of the fidelity scores across the different sessions. So that was a challenge too that we were struggling to overcome. So what we came up with as a solution was the idea about using technology-based interventions. So can we translate SAFE to a digital delivery format? And we called that Pathways for African American Success. So on one hand, the digital delivery could make the program accessible at any time. And circumvent challenges with delivery. So the big implementation gaps that we saw. But on the other hand, there was a lot of skepticism about access to technology, familiarity, comfort, and so forth. So especially for our grandmas, we had a lot of grandmas involved in raising grandchildren, and we faced a lot of skepticism about whether they would be willing to participate in an intervention that was delivered digitally. So we did a trial. We compared, we had 3 conditions, an e-health version, a small group, and then a literature control. This one was done in Tennessee. And we actually found that the participation in the kind of e-health version was double that, or almost double that of the small group. And grandparents were our biggest participators. So I love that fact. So we did multiple analyses. This is just an example. where this one's focused on depression, but incorporates, discrimination as kind of a culturally specific risk mechanism. And we did find positive results of the intervention. Again, multiple studies showing positive results so that we solved the problem, right? But no, we didn't. So in terms of implementation, it was good in the sense of there was, like fidelity was less of an issue. Participants could access anytime, anywhere, and that did result to higher rates of participation as well as better outcomes. But just thinking about the maintenance or sustainability piece of implementation, how would an app like or a program like this be promoted? Just kind of getting lost in the sea of apps. There are so many these days, and also maintaining the technology. So the past program was built, for example, using Flash, and now Flash is no longer available, so it has to be rebuilt. So thinking about how are we going to maintain that technology and absorb those costs. So just to kind of summarize, did we address the implementation gap? No, not completely, aspects of it for sure, but reach is still a major issue. And we've come to the conclusion that it really needs to be embedded within systems. So thinking about the systems, either that like children experience, family, school, religious organizations, healthcare, and then also those that their parents are embedded in. So one aspect that I've been let me just go back, just a reminder that when we are thinking about the systems, we want to focus on implementation contexts that reach the population that we're trying to serve. So one of the systems that I've been spending a lot of time working in is primary care. So there's been a lot of recognition that primary care has a lot of potential for delivering family-based preventive interventions of late in the past maybe 10 years. It has, kind of a physical and behavioral health focus that matches what we do. There's reach. I think this is probably the most important one, reach across racial and ethnic groups. So the stats are somewhere around 85% of all adolescents have a primary care visit at least once a year, and that's across groups. There's longitudinal contact with the same pediatrician, parent involvement, and especially parents have a lot of respect and trust in their pediatricians. Last but not least, there are existing billing structures. So one of the problems with a lot of interventions is that there just aren't ways to fund them. But in primary care settings, there actually are ways that we can fund these things. So I'm going to talk a little bit about the Family Checkup for Health. So it's an assessment-based, individually tailored preventive intervention for delivery in primary care. It's based on the original Family Checkup model, which is NIDA and NIMH funded tailored preventive intervention for families, which includes an initial interview, a family assessment, and then a motivational interviewing based feedback session. And then the rest of the program is all tailored based on the needs of the family. So we took many steps to try and implement this. I was working with Phoenix Children's Hospital and with their care coordination program. And they were really interested in bringing in a preventive intervention for families. And so we tried multiple times, but really came to the conclusion and actually did a survey of the providers to look at like their kind of perceptions about whether they're priorities for their patients. And obesity and nutrition was number one. So that was really like all of their focus was really on that aspect of it. And parenting and child behavioral health was number two. So although they saw it as important, they didn't see it as primarily aligned with their mission to focus on parenting and behavioral health. But the family checkup has been tested in multiple trials and has demonstrated improvements in parenting, child self-regulation, school readiness, lots of academic outcomes, as well as substance use initiation, onset, mental health for both parents and kids. And these trials were done across, actually, there was there was work with adolescents and work with early childhood as well. But around the time that we were doing this, we found effects of family checkup on improved nutrition quality and obesity and excess weight gain. And so that was kind of the hook where, when we showed this, and it really does speak to the fact that parenting interventions affect all the good things that you want for kids. When we could show this, that's when people really started to get excited. So, kind of going back to like this heuristic framework, I think we can really incorporate contextual adaptation of interventions as well as the cultural piece. So kind of thinking about what is going on within the primary care setting specifically. So, one thing is thinking about how we can address the concerns of the providers related to obesity and so forth. There's also a lot of focus kind of related to that. Actually, let me just jump to the next slide. These are some of the adaptations that we made to make it more of a whole child, whole health, whole family health intervention, which was deemed to be more appropriate for primary care settings. And so one of the big things that we looked at was in terms of social determinants of health. And there was a big initiative in particular related to food insecurity in this primary care site that we were working with. So we made these adaptations to focus on, again, whole child, whole family health, making those connections between parenting, child behavioral health, and child health behavior. So we know, for example, how much sleep or screen time adolescents get makes a difference for their behavior in ways that like parents care about. They get grouchy and parents don't like that. So thinking about how can parenting affect both of those things was a big aspect of this work to make it fit within the setting. But then also, we incorporated this kind of extension of the care coordination approach or resource coordination, where we were really focused on finding out if families were struggling with social determinants of health and connecting them with resources. So that was a big change from what had previously been done with the family checkup model. So then we tested this adapted model with 240 families in 3 different primary care settings. And our eligibility were English or Spanish speaking caregivers. And we were focused on, because of the focus of the priorities of the clinic, focusing on kids who had elevated BMI. And we did assessments at baseline, 3 months, 6 months, and 12 months. Oops. And so you can see from our participant demographics that we were really able to engage with a large percentage of the kids who are most negatively impacted by health inequities. So it was 68% Latino, 38% of the parents spoke Spanish as a primary language, the majority were on Medicaid, and over half experienced food insecurity, as I was mentioning. So we did find in this study that we had a positive impact on the child behavioral health outcomes that we had found in previous this is a similar model to what we looked at in previous family checkup studies. So by adding in this whole child health component, we didn't wash out any of the effects on parenting and behavioral health outcomes. So that was good. And then we also wanted to look at, though, did we also have this impact on family health routines and child health behaviors? And we did see that as well. Kind of going back to that piece about contextual adaptations, we also wanted to see, did we actually have an effect on food insecurity, or what role did that play? And these analyses have not been published yet. They're kind of like not even hot off the press. They're like still in the dough stage, but we have looked at the impact of family checkup for health on food insecurity and found moderation effects such that families who had food insecurity, we did see a decline in food insecurity for those in the intervention condition. And we found that was associated with parents' depression, which is kind of a widely recognized kind of correlational association that's out there in the literature, and that has an effect on child's emotional problems. So there is this indirect effect that we hadn't previously accounted for, that it was really kind of tied to families' experiences of social determinants of health. And then we repeated the analyses for child conduct problems and found a similar pattern of results where for families of experiencing food insecurity at baseline, we had improvements on parental depression and child conduct problems through reductions in food insecurity. So then we also wanted to look at implementation. So we looked at, just following the equity informed re-aim model. First, we started out by looking at reach. And so we kind of conceptualized it in multiple phases. So from, the families who were approached to those who consented to being screened, to those who were eligible and enrolled, those who completed the pre-test, and then for those assigned to the intervention condition, how many of them initiated services. And so what we wanted to see was kind of an increase, or at least like steady rates, where for our families in groups that were most affected. So I'm talking about Black, Latino, and Native American kids are most at risk for obesity during this age, and then also like the development of substance use later on in time. And so we really largely did see an increase where the majority of families who were approached were Latino, but also big numbers for our Black and Native American populations. And there was somewhat of an increase across each of these stages, whereas for the kind of majority population, we saw more of a decline. So fewer of them were approached, but then at each stage there was less engagement, which does kind of speak to the ability to address inequities through this model. So we were really pleased to see this. We also looked at fidelity. So was there difference in how the sessions were implemented across racial and ethnic groups? So what we did, because of our variable sample size, was we did combine our priority population against other racial and ethnic groups. So this is, just keep in mind, primarily Latino families. But we did not see really any differences. These are the different dimensions of fidelity in the family checkup and family checkup for health models. We didn't really see any differences in how the intervention was delivered. And we didn't see any differences in terms of how much the participants were like actively engaging with the sessions. We also didn't see, because it's a tailored intervention, they could participate in as many sessions as they wanted to. So we did not see any differences in terms of the number of parenting sessions that they participated in. We did see differences in terms of the referral sessions. So that's where we're connecting families with resources. And the way that that turned out was that we spent more time with families in our priority population, focused on connecting them with community resources, so food insecurity and so forth. So this was actually a difference that we were really happy to see, that we were engaging more with them on those needs. So if you build it, will they come? If you build it in the context, will they come? We're still struggling with that a little bit. So just want to kind of share the current state of things. So in this first trial that we did of the family checkup for health, None of the participating organizations was able to sustain implementation um, following the trial. And primarily, what we found was the big issue was that, like, with a tailored intervention, it takes a lot of upfront kind of conceptualization time. So, looking at the results of that assessment, coming up with a case conceptualization and possible recommendations for families. Um, and that, unfortunately, like, that piece of the model is like not billable. So the people who are implementing it, they're taking the results of the assessment and trying to come up with that. There's a steep learning curve because there's so much information to kind of synthesize that it could take, like, in the early days, like an hour. And they just do not have, like, behavioral health folks in primary care are really just focused on, like, making it through the day. They don't have an extra hour to for each participant who's coming through, or each patient that's coming through, to do this. So that was kind of the big sticking factor for that, because we were able to figure out how they could bill for all of the other aspects of the program. So what we have done since is that we have a current study funded by NHLBI, actually, where we have developed a clinical decision support tool, and which synthesizes the results of the assessment and provides recommendations for follow-up support um, based on, like, the kind of, it's kind of an algorithm of, like, if-then statements with what the data is in the assessment. So that's where we are now. We're still in the middle of that trial, so hopefully I can come back in a couple of years and talk about how that went. But that's, I think, yes, and we're kind of good on time. I'm just gonna reinforce some of the key takeaways. We have a need to invest in prevention that affects a whole range of positive outcomes for youth, and including substance use initiation and escalation. When we think about equity, we need to focus on both the effectiveness of interventions, as well as whether those interventions can be implemented in contexts that serve families. And to do that, we really need to think about culturally and contextually focused adaptations for interventions. And then this really does depend on iterative and longitudinal relationships with organizations, because it's a learning process. And each time you try and implement something, you will learn something new about a way that you could do it better. And with that, I would love to open it up for questions.